Hi everyone and welcome. My name is Ellen McNally. I'm the Marketing Director here at MDeverywhere. For those of you who are not aware, MDeverywhere is a full-service revenue cycle management company. We provide process-built, cloud-based technology combined with expert back-end billing services. And our mission is to maximize collections and revenue for our physician clients. I do want to thank all of you for joining us today. Our topic, ICD-10, very relevant to all of us. What to do and when to do it. It's my pleasure to let you know that we have our guest speaker, Lisa Asbell. She is the president of TrainRX. She's also a registered nurse for almost two decades, certified HIPAA professional, certified identity theft risk management specialist, and of course an ICD-10 transition specialist. Lisa is the only ICD-10 speaker in the United States that is also a member of the prestigious National Speakers Association. She's presented over 1,000 times in over 500 cities across the country, has trained more than 50,000 healthcare professionals in live seminars. She's published over 30 articles in various healthcare-related publications, written programs and policies to help private practice comply with legislation. She has a fun and engaging training style, which you're all going to get to enjoy today, and we're really excited to have her be our presenter today. Before I do turn it over to Lisa, I'd like to just cover a couple of housekeeping points. All right. Number one, we are recording this webinar, and everyone will receive a link to the recorded file following the webinar. All right. So yes, you will all get a copy. Lisa has also built a couple of minutes in for some question and answer time at the end of the presentation. So if you do have a question during the presentation, just type it into the questions chat window that shows up on your control panel as it comes up. We will answer as many as we can during the time allotted. Any of them that we can't answer live on this call, we will follow up with individually. So without any further delay, I do want to hand the mic over to Lisa Asbell, our ICD-10 training specialist, for her presentation on what to do and when to do it. Lisa?
Hi, Ellen. Can you hear me?
Can hear you perfectly.
Awesome. Good noon, everybody. And for some of you guys, I guess it's morning. So I so appreciate you guys being on the webinar today. And I so appreciate MDeverywhere sponsoring today as well. And I'm excited to share the information with you guys. And, you know, as I was listening to Ellen announce me or introduce me, I thought, you know, to you guys being a member of the National Speakers Association, or to me, for the fact that I'm a member and the only ICD-10 trainer in the world that's a member, it only means that this is not going to be boring. That's really what it means. It's not to impress you, but really just so that you know this is going to be fun and engaging, and you're going to get real stuff today. You're not just going to get a lot of legal mumbo-jumbo that you don't know how to decipher. You're going to get some great information today, and we're about offering you solutions. This is a big deal. This is the biggest change in healthcare in 30 years, and we are solution-driven. So hang on to your hats, and if you have somebody else with you today that you need to put on speakerphone or that kind of thing to include more people in your organization, that's just awesome, and we're happy to have them. So again, I'm happy to be here, and we're going to get started. The purpose of today's webinar is really twofold, and the first is, you know, we have a lot of people from a lot of different backgrounds, from hospitals to very small one-provider practice today on the phone and on the webinar. And I'm pretty sure that we probably have billers and coders and managers. We probably have just a real big collection of people today. But I don't care where you are in your organization. If you are going to be assigned a task of gathering information or in charge of the transition to ICD-10, my goal today is to motivate you to fully engage your organization in this process. Guys, this is going to take a village. It's going to take a team. It really, truly is change management. We're going to talk a lot today about private practice, and then I'm also going to point out the differences, and really for hospitals or large practices. But the bottom line is it's all the same process. It's just on a much bigger scale. So my goal today, again, is to motivate you guys to engage your organization. The second thing is to give you easy to understand information so that you can get started in the transition. You know, I've been a trainer for many years, just like I've been a nurse for longer than I care to admit. But ultimately, the one goal that I always have when I present is I want people to walk away with going, what do I do tomorrow? Whether I'm training in HIPAA or OSHA or ICD-10, I want you to go back and say, I really do know how to get started with this. Where do we start? First, we're going to talk about the history and the facts of ICD-10, and then we're going to talk about the 10 steps to getting ready. I am not going to belabor the points about the history and the facts because some of it I believe you guys already are very aware of. I've had my finger on the pulse of ICD-10 now for many months. I've seen a huge change in just the last few weeks at the number of people who now really do realize ICD-10 is going forward. You know, I don't have a slide, but I first want to cover, before I get into the foundation and background, I want to talk for just a second about some ICD-10 myths. And the reason I think it's important to point this out is because you're going to hear a lot of stuff, and you probably have heard a lot of stuff. One of the myths that I hear very, very frequently is that ICD-10 is associated with Obamacare. And the fact is, the groundwork for ICD-10 was laid back in 1996 with the changes in HIPAA. So it has nothing to do with Obamacare or the HITECH Act. It's a totally separate thing. However, it is part of moving to an e-health environment. So that part is true. Another myth, and I think it's probably the one that I hear the most across the country, is that it's all about coding and IT. IT and coding are very significant parts of ICD-10, but they're only one part and one piece. And if you're going to, or you decide to outsource your billing to a professional billing service or a revenue cycle management service like MDeverywhere, if you were to make that decision, they of course would take some of that burden away from you. But the other steps that you need to do, the other part of the process that you need to get started probably 6 months ago, has nothing really to do with coding and IT. So I want to clear that up because that's a myth that's out there. The third and probably maybe the biggest myth I hear is my EMR company is going to handle it. I don't need to worry about it. From being in the hallway at a large facility or a hospital to a very single provider practice at one of the medical societies I speak at, will have a provider say to me, my EMR company is going to handle that. And as we move forward today in this webinar, you're going to understand why there are multiple steps for you to do. If I were to count them, I would think there's probably between 80 and 100 steps for you to do that really don't have a lot to do with IT and coding, and we'll talk about that. Now, they're not difficult steps. They're steps that, of course, you can do, but they must be done, and we're already 6 months behind. So let's talk now a little bit about the foundation and background now that we've cleared up the myths and so that we're all on the same page. CMS is committed to ICD-10, whether it's CM or PCS, because of the millions of dollars and the hundreds and hundreds of hours of groundwork that have gone into preparing ICD-10. Let's talk about ICD-11. ICD-11 will probably be published by the World Health Organization in 2015. Because of our unique multiple payer system, it takes 10 to 15 years to do the clinical modifications, which is what CM actually stands for. So when you hear your provider or you hear somebody else say, oh, we're probably going to skip 10 and go to 11, nothing could be further from the truth. Because even if we do decide to go to 11 eventually, and we certainly may, you're talking about 10 to 12 years away. So I want you to clear that out of your mind. 9 was frozen. 11 is 10 to 15 years away. 10 will move forward on October 1st, 2014. And please don't let anybody confuse you otherwise. The next thing I want to mention on this slide is I know that the numerous delays have created a disservice to our providers and to you, the person or the people in charge of your transition. Let me just tell you a little bit about my heart. I have served in private practice and served in the healthcare community now for almost 20 years. I can't even believe it's been that long. Much of that time as a wonderful, exciting career as a labor and delivery nurse, but some in private practice as well. I have a passion for healthcare, and I have a passion for private practice. And let me just tell you this straight up. If you think that you're not going to need some outside resources to make this transition to ICD-10, you're sorely mistaken, and it's why you're here today. You will need outside resources. You know, if you're a small private practice, do you need to go out and spend $15,000 on a consultant? Absolutely not. Is it going to take you hundreds of hours or dozens and dozens of hours and a lot of legwork if you don't get some outside help? Yes, it will. And there is a middle ground and there's a happy medium, and I'll talk about that. But I realize that the headache that you have, and I realize the multiple hats that you wear, whether you're a CIO, a CEO, a CFO, a practice manager, a billing manager, no matter what role you serve today. And let me speak to this. I know there are people on this webinar today that have dozens or hundreds of healthcare providers as clients as well, and good for you for being on today, because you too need to reach out, and we need to make this a community effort. Biggest change in healthcare in 30 years, and I know I can speak for MDeverywhere, and I certainly speak for myself and TrainRX and what we do, that our goal is to make everybody and make sure that everybody gets paid on October 1st, 2014. And we do have a passion for you and want to make your load lighter. More about the background and history. I'm not going to spend a bunch of time here. I just want to say it is the biggest change in healthcare in 30 years. Guys, I've heard everything from on the scale for the 50-10 conversion that happened in January of 2012, and I bring that up because that's a big conversion that we're having, as just like meaningful use with EMR or EHR, however, whatever terminology you want to use. Let me just say this. Do not confuse 50-10 with ICD-10, because 50-10 was a walk in the park compared to what ICD-10 was. ICD-10 is a change management. ICD-10 impacts and affects every area of your practice. 50-10, people did have some issues with that data conversion and that upgrade. There was, I know, some issues maybe with Medicaid and Medicare with a little bit of delay in payment. Guys, this is huge, so don't confuse it. I think it's important to point that out because I'm getting some feedback from various entities about that, and I want to make that clear. You also see on the slide that ICD-10 will totally replace ICD-9 coding, the ICD-9 codes, other than date of service, of course, for things that happen or visits or encounters that happened before October 1st, 2014. The final rule was announced on August 24th, 2012, with the final deadline of October 1st, 2014. And again, don't sit back thinking it's going to be delayed again. They've made it clear it will not be delayed again. Hoping that ICD-10 doesn't happen or it's going to be delayed is not a good strategy. You have got to jump on this, and you've got to get prepared. Do you realize that the U.S. and Italy are the last two industrialized countries in the world to convert to ICD-10? Now, there's a whole long reason for that, but ultimately it comes down to money, and it's attached to CPT codes, and it's attached to revenue generated from various organizations. So it's attached to money. But let me tell you this, if you're a provider on the call today, or you're on the webinar, or you are a CFO and you're thinking about your bottom line with ICD-10, ICD-10 is not all bad. There are some wonderful, great benefits to ICD-10, and we're going to talk about that. The second bullet point here says an enormous amount of time and money have gone into preparing. Guys, that's why it's not going away. That's why it's not going to disappear. That's why it's moving forward. And guys will see that Dr. Mastashari, the National Coordinator for Healthcare IT, said at the HIMSS ICD Forum in late June or early July that there's going to be no more extension of the deadline. And I will say something that I think is kind of just a funny aside note. He actually resigned last week and resigned his position with the ONC. So I think that that's unique in its own way. But the point is, it is going forward. It won't be delayed. What's wrong with ICD-9? If you're a coder or biller on the call today, you know what's wrong with ICD-9. You know that we have many categories that are full. You know that the structure limits new codes that can be created. The medical terminology is outdated. It's 30 years old. Number 3 is the most important part of ICD-9 as far as the problems with it. It lacks specificity. I've often thought that that S in specificity should be a dollar sign, because for you moving forward, specificity equals money. We don't want ICD to stand for I can deny. We want ICD to stand for I can document, because some of the changes we'll talk about moving forward is greater specificity. It goes back to documentation. But the problem with ICD-9 is those codes lack that specificity, and it causes a problem with streamlined automation in payment. So it does limit operations, reporting, analytical processes, and it absolutely lacks the specificity to process claims and reimbursement. I'm going to talk about that and give you some examples. ICD-9 is broken. It's 30 years old. The categories, many of the categories are full. It's time to move forward. Let's talk about benefits of ICD-10. You know, I could probably spend the entire webinar today talking about the benefits of ICD-10. There are many people with no financial attachments whatsoever that will tell you the ICD-10 benefits are huge. Number one, the usage of current medical terminology. Guys, we're still talking about things with ICD-9 that we no longer classify or call anymore. It's a new day. ICD-10 is part of our new e-health environment, but we need that better terminology. Also, the uses of codes with greater specificity and detail, and again, I'm going to give you some examples, but if you caught me in the elevator and say, give me an elevator speech on ICD-10, I would say, your providers need to document, they need to be more specific, that's how you're going to get paid. That would be my elevator pitch, along with, it's not just coding and IT, so don't get caught up in that. Improved coding based on advancements in healthcare. Guys, this is going to make for better healthcare. When your mother or your sister or your spouse can go in and have a below-the-knee amputation and not have to document whether it's left or right, or use modifications to make sure that it's left or right and get paid, that's a breakdown in healthcare. If I ask you today to pull a report in your EMR on patients that you treat with asthma, you could do that. But if I said pull a report on patients that you treat with mild, persistent, intermittent, patients with allergies, or patients that have asthma because of tobacco smoke, you could not do that. That greater specificity is going to provide two things. Number one, better healthcare measure as far as your PQRS reporting, right? And also lesser rejected claims, because the more specific you get, it's better. It's going to have faster reimbursement and higher reimbursement. If I can prove you have sicker patients, you know, for years we've said insurance companies just don't want to pay, and we know that's somewhere in between the truth and a lie, right? But ultimately, at the end of the day, ICD-10 is arming us. I mean, basically, we now have ammunition to say we are treating sicker patients. We have the EMRs to back that up. We can pull those reports. We have the greater specificity in our documentation moving forward with ICD-10. We really are armed to get paid with ICD-10. It is a powerful, powerful thing about ICD-10 if you can use it, right? And we want to teach you how to use it. Let's look at how ICD-10 increases the specificity. Here are charts that the differences between 9 and 10, and I won't go through all of this because all of you guys will have access to this online and you can go back through. But basically, if we combine for private practice and hospitals or inpatients, so if we combine PM and PCS, we're talking about from 30,000 codes to over 170,000. Trust me, you don't want ICD-11 anytime soon because it's well over 250,000 codes. So when you hear providers talk about ICD-11, now you can shut that down altogether because number one, you know it's really far away, and number two, it's actually worse for you, okay? The other thing I want to say is don't be overwhelmed by the number of codes because greater specificity is why there's so many codes. But I also want to point out here too, guys, if you don't know the level of skill of your current billers and coders, or you're concerned there are issues there, this is the best time I can think of to think about outsourcing to a revenue cycle management or professional billing service like MDeverywhere. Because for coders and billers that really aren't up to par, this certainly may be an overwhelming process. Now, are you still going to have to do all these other steps I talked about? You are, and we're going to talk about those. But ultimately, you need to think about these changes. But let's look at how the specificity is actually good for healthcare. You see in the middle of the box on ICD-10, it's flexible for adding new codes, which we definitely need. It's very specific and it has laterality. Some of the other areas of specificity, for instance, are the encounter type. So we know that it's the initial encounter or the subsequent encounter or a sequela visit. And most of you guys will not know that terminology, sequela. It's kind of a new word. And basically, here's the bottom line to what that means. I come in and I present with a cut on my initial encounter. And then I come back and I get my stitches out on a subsequent encounter. And 3 weeks later, I got some type of infection. That would be called a sequela visit. So that's terminology you guys haven't used before. But there's also greater specificity with in respect to the trimester of pregnancy. They don't just want to use weeks anymore. They actually want to use trimester. So that's some of the areas that are more specific. And we'll talk about documenting in a few minutes. All right, let's look at what's in ICD-10 that's not in ICD-9. And here's a great example. And, you know, unfortunately, if we have orthopedic surgeons today or orthopedists on the phone, and I know we do on the webinar, I know for a fact that that will overwhelm you. I don't have a slide for this, but basically open patella or a fracture of patella has 2 codes right now, open and closed. For ICD-10, it's over 400, and I think the exact number is 480. But this is an example of why 9 is broken and why 10 is better, and why you would get better reimbursement if you did this correctly. The example is that Linda fractures her right wrist. A week later, she fractures her left wrist. You can see that 9 doesn't differentiate the left or the right. It also doesn't talk about which visit. Is it initial? Is it a subsequent encounter? It also doesn't say, is it routine healing, delayed healing, the type of fracture, right? So it actually gets even more specific with the type of fracture it is, whether it's open, closed, again, with healing as well. So you guys can see why we're going from 1 code with this to here we have 7 codes, but ultimately more codes because it's greater specificity, which again makes for better reimbursement if you do it correctly. And that is really the key, is doing it correctly. All right, let's talk about diabetes mellitus. I love to give this example because you'll see here that there's actually 40 different codes, and many of you guys on the phone today, you know these codes because this is something very common that we use a lot, right? Such a huge population of the United States is obese, and because of that, diabetes mellitus is an issue. But actually, ICD-9 has a total of about 40 ICD codes, ICD-9 codes. For ICD-10, it's 318 because it includes all of these underlying conditions, right? So that's a breakdown that I won't go into. Again, you know, I'm not a coding specialist. I'm a transition specialist. There are coding specialists out there. Let me talk about the experts weighing in, and this is where we get that I knew this was coming. When you think about a statement that David Winkler with Blue Cross Blue Shield says, and I'm sorry the type is not perfect on this, guys, my fault, but physicians may be ICD-10 compliant, he says, but if they abuse other unspecified codes, payment will not occur. Let me tell you guys, right now there's some legislation out there that you actually could get some type of leniency period. That's not going to happen. There will be no leniency period. You either get this right on October 1st, 2014, and the next 15 months that you need to spend in preparation leading up to it. Many of you guys are already 6 months behind. For many of the people on the webinar today, this is the very first thing you've done within relation to ICD-10. I am called every day and reached out through in social media by EMR companies, by various types of companies that maybe do HIPAA or work in various parts of the industry that say we don't know really how to help our clients. We need help helping our clients. So, you know, they're saying that Annie Boynton of United Healthcare says, hey, the insurance companies are ready. It's everybody else that's not ready. And guys, we've got to take this serious, and I applaud you for this being, many of you, your first step today, and I'm going to give you what you need. Jerry Leone, who is the past president of the AAPC, has said a couple of very important things, and this is an impressive lady that does know everything there is to know about coding. And she says coding productivity is going to be cut by 40% initially. There's no doubt about it. When you do in-house coding and in-house billing, you're talking about a 40% cut. She also says that in a chart audit, and I'm going to talk about that at the very end today, that in a chart audit, when they pulled charts to see how the documentation was and if they could pick an ICD-10 code based on ICD-9 documentation, she also says that 40% of the time the providers had not documented enough or clearly enough that they could assess the right codes. That is a big issue, and we're going to talk about how we can help you remedy that issue. All right, so now that we've cleared up, let's recap. The myths are, my EMR company is going to handle this, and they are not. They will be ready with their coding. They will be ready with upgrades and templates and some of those things. There's no doubt about that. But ultimately, they're not going to handle the moving parts in your office or in your facility if you are a large facility or a hospital. Only that project manager and the people on your team can handle that. So that's one myth. The other myth is that it's all about coding and IT. For today, it's not all about coding and IT unless you're going to decide to outsource it. If you're going to decide to outsource it, then that's a decision that needs to be discussed immediately. Otherwise, as far as training, those are things that you can do later on in January or February of next year, and I'll talk about that. Then I want to make sure we understand ICD-11 is out, ICD-10 is moving forward, and the firm deadline for compliance is October 1st, 2014. This next slide I want to show you, I realize that we have probably some large facilities today or some consultants or people with companies that serve large organizations. But I will say to you, the timeline is much the same. You could add a few months to it if you've got a large organization. Many large organizations were actually preparing and well into their preparation over a year ago or a year and a half ago before it got delayed. And again, I know that delay has created some issues. We don't want you to have issues. We want you to see where you are. And if you're not following this timeline that CMS put out there, which is very similar to every other organization I've seen that does project management or that works with ICD-10 implementations, they're all similar. So you can see where you are. If this is the first thing you've done, you're 8 months behind. Internal testing should have already started in April of this year. We should have already been doing chart audits. We should have already been talking about clinical documentation improvements for providers. We should already have a steering committee well into engagement. Let me say this. I spoke last week for many critical access hospitals. One doesn't know what the other's doing. Guys, that is tragedy for us. That's tragedy for us in healthcare because the critical access hospitals I was speaking to, they don't really even understand necessarily who's in charge, and it was all over the place. In one facility, a coder was in charge. In the next facility, the IT person. The next person says our EMR company's handling it, which we know is not true. So really, I again have my pulse on this, and my finger on the pulse of it, and it is changing. It is getting better, but we're very far behind. We've got to move forward. These now are, we're going to get into the steps to get your organization ready. And guys, I apologize ahead of time. This is going to be a lot of information for you to take in, and I realize that. And we do have resources. We do have help. I am always available to anybody for you to be able to reach out to me to give you some more information, always. But this is going to be 10 steps that I'm going to include a lot of information. We're going to talk about financial impact. We're going to talk about why it's not all about coding and IT and why it's so imperative that you get started this moment with your project. And the first step in that is designating or hiring a project manager. If your practice manager just does not, especially the larger your practice and the more hats that she wears, or even in some organizations with only 1 or 2 providers, your project manager will probably be your practice manager. In a hospital, it can range from everywhere, from the revenue cycle director or manager all the way up to the CEO, depending on the size of the facility. So designating a project manager and a champion is absolutely crucial. In a small facility, you're going to designate a team, and maybe that's just 1 or 2 staff members, depending on the size of your organization. If you're a larger facility, we're going to call that a steering committee. but ultimately you've got to have a team of people. The ideal situation would be a person from each department if you could do that. If you're a very small provider, that's not possible to do. Ultimately, establishing clear communication channels. I know in the program that I designed for our clients, I put some forms in there for communication because I realized, especially in smaller practices, that if you have a couple of people that you've assigned roles on your team, you've got one person sending you an email, the other person using a form, the other person yelling down the hall, hey, Sally, I want to let you know that I did this today. That's not going to work for this. You see the picture that I have there. There's a lot of moving parts. It's not necessarily difficult, but there are many moving parts. And then the last bullet point is so crucial if you're going to think about evaluating revenue cycle management as a partner to help you alleviate some of the stress. That's the time. The time you do it is now. The time you do it is right away versus waiting for many months to do that. That could spell tragedy for your organization. Let's talk a little bit about managing the project. And remember, this is written primarily for primary practice or smaller outpatient practices, but ultimately you can just multiply everything times 10, and that's probably where you're going to be at, okay? And I'll talk about more of that with money, with budgeting, but first thing that you should know is this is going to take maybe up to a couple hundred hours. Some of that time is going to spend, of course, training. Some of that time is going to be spent in evaluating, putting your project together. A lot of it is going to be spent in communication with your vendors, and I'm going to talk about that extensively. If you are a small private practice or a medium practice, you should really start thinking about now investing about 5 hours a week. If you do it and you start immediately, you can manage that and you can break that down. Same thing if you're a large organization. If you start investing 10 hours a week now, and I know when I'm telling you that I understand from years of working as a nurse, there were many shifts that I never even got a bathroom break. So I understand for you guys that it is no different in private practice in the whatever role you have there, or in a hospital, whatever role you have, you're busy. And to be able to invest extra hours, that is why some people will hire outside project managers, or a large organization should hire a whole team from outside. It is smart. It's what makes sense to do. But there are dozens of steps to do, but many do involve contacting your vendors. Even if you only need a small team with 1 or 2 staff, and that's all you have, that's okay. These are some of the things that you would consider. Maybe contacting vendors or investigating vendor options, of course. You might put somebody and assign them that role. You might have somebody that they're going to have the role of looking at training. How are you going to do it? Training is going to be based on your budget. The more money you have, of course, the better you can train. We have a training option for our clients that's fantastic, but you're going to have to address that. Also, you're going to have to think about having somebody address a financial impact or a financial a gap analysis. If you're at a large organization, you know, and I'm talking about 50, 7,500 bed hospital, you know, that gap analysis or assessment from an outside company should probably cost about $15,000 or $20,000. Let me also throw in here with these larger organizations, if you already have a team and you're already, you know, involved in these steps, do not think you have it all covered if you don't have a checker. If you don't have an outside person come in and take a look, and I always say this, you can use our products or our services, our company or not, it doesn't matter, but I'm telling you as a subject matter expert and somebody who spent hours and hours on this, you need to have somebody from the outside reevaluate where your team is, especially if you've not outsourced it or hired an outside company. Same thing, project manager, when you put the point of managing the project, if you're at a smaller private practice or smaller organization, is you're doing that. You're not just turning these people loose. You've got to make sure that they're doing what they're supposed to be doing. And again, this is an all hands on deck approach. You cannot just think you're going to plug people into this thing and get paid on October 1st. You're not. The other thing you might consider if you're not large enough to have a CFO is you might assign somebody in your practice or your office that maybe does billing, or maybe this would be you. you would actually be putting a budget together, and I'll show you a sample budget, what that looks like. And then, of course, the communication plan, that is crucial. One of the biggest mistakes you can make is not having a clear communication channel. Again, too, when it gets down to it, as we move forward, there are many things you need to be doing yesterday, and there's some things that can wait or that you can kind of push back till January of next year. IT issues is one of those things. As long as you have somebody lined up that you know you can count on, that's the important part. Guys, I want to talk about here, and I wasn't going to mention this, but somebody brought it to my attention over the past few days. I want to talk about supply and demand with consultants, project managers, even revenue cycle management companies like MDeverywhere. The closer that you get with supply and demand to the biggest change in healthcare in 30 years, there are project managers now for small projects in private practice that can be hired for $35 to $40 an hour. 3 months from now, 4 months from now, that number's going to go up to $200 to $300 an hour. There are so many reasons why you take this seriously and you get started and you get your providers and you get buy-in and you get your team leaders if you're in a larger organization and you say, we better jump on this and start doing all these steps, and we better get on paper. If we're going to hire extra coders, there's going to be a huge shortage of coders, a huge shortage. I think they said as many as 70%. I mean, again, that's why you might want to think about outsourcing, if that's at all an option, or if you've ever had that little thing in your mind like, oh, I wish we could outsource. You better think about it. There's going to be a huge shortage moving forward. The second thing I want to talk about, or the second step, is performing an impact or a gap assessment. And guys, here's the thing. In a large facility, again, this is going to be called maybe more like a gap analysis, and you're talking about paying $15,000 or $20,000, which is well worth it to make sure that you're doing good. But the other thing I want to talk about is, you know, how the workflow and the business processes, everything is impacted. If you could imagine with me, in your organization, I don't care what size it is, everywhere an ICD-9 code touches, there's going to be an impact with ICD-10. Some of it will be business and workflow, like with referrals, and I'll list some of those out in a minute. I don't want to try to call them from memory. But some of that is going to be financial. Some of it is going to be, guys, human capital. There will be coders that retire over this. There will be coders that are close to retirement anyway, and this is going to, you know, throw them in. There will be people that want to get married during that time, family members. I mean, you're talking about looking at every area an ICD-9 code touches, not just coding or IT, but in billing and claims. And again, I'm going to go through that. Also, I want you to understand, too, that partnering with a billing company like MDeverywhere can offset some of the costs that you're going to face with this financial impact with ICD-10. And that's an important thing for you to look at. Let's talk more about why you would conduct a gap assessment or an impact assessment. First, you have to know where you are. You have to understand. You know, I've worked with providers for many years, and I guess, and I'll say it because it's kind of funny, and I hope you guys enjoy it, but one of the statements I've made over and over that have made me semi-famous in the world of speaking is that providers and CFOs and CEOs do not care about labor pains. They want you to show them the baby. And that comes from 20 years as a labor and delivery nurse. Thank you very much. But ultimately, at the end of the day, these people that deal with money, they have to know, what is this going to cost me? Guys, do you realize that Bank of America, that Fifth Third Bank, that SunTrust, and many other national banks have set up whole divisions just for financing because of the impact with ICD-10? Do you realize that the Center for Medicaid and Medicare Services say that you need 6 months of operational cash flow for the financial impact of ICD-10? I mean, do you realize that how significant that is? That when many of you on the webinar today are saying, I really haven't even started, or I have a whole sling of clients, you know, health hospitals, other providers that I haven't done anything for. I mean, this is really, really huge. You know, such a big opportunity, and the financial or the impact assessment really is the very first step to making this right. I want to talk specifically about some of the areas of impact because I think this is important for you to see that what I was telling you about the myth of ICD-10, that it's just about coding and IT. When you think about your clinical staff, and again, remember, you're thinking with me, everywhere an ICD-9 code touches, an ICD-10 means there's some type of impact. So, you know, your clinical staff, of course, documentation with physicians is the number one, absolutely the cornerstone to making ICD-10 work, is getting provider buy-in and getting these physicians to document better. And basically, they need to tell a story, and we're going to talk a little bit more about that. Think about your third-party payers, your billing, your coding companies, your clearinghouses. You know how I said that one of the myths is my EMR company will handle that? And it always bothers me when somebody says that. Well, they say that until they attend one of my seminars, because when they see this long list of areas of impact, they realize that their EMR company is not going to handle their internal office processes. They don't handle scheduling. They're not going to handle forms. They're not going to handle super bills, lab, radiology, OT, PT, DME. What about referrals? What about insurance verification, pre-authorization? What about training? What about human capital? What about staff that's frustrated and decide to quit over it, right? So all of these areas of impact are significant. So don't ever let anybody else ever tell you that, number one, it's about coding and IT only, and number two, your EMR company is going to handle it. You know, EMR companies are doing a great job for what they're facing and those huge changes. But I know what you've gone through, too, working with EMR companies and trying to achieve meaningful use. And now we're moving into 2 and then 3 to come. I mean, there's a lot of huge changes to healthcare. And I know, again, that this information probably for some of you guys is overwhelming, and I don't mean it to be overwhelming. I mean to give you real-life suggestions for how you can make this work and what you really need to do so you're not in the dark. But again, ICD-10 impacts every area of your practice. It's not just those areas I've already mentioned. Coding, productivity, your software. Do you need software upgrades? Might you need additional hardware? What about hiring additional people for denial claims management? How easy do you think it's going to be to find those people if you don't already work with maybe a staffing company that will guarantee you somebody? All of those are areas that you need to address. And then the third step is getting leadership engagement and buy-in. I had a lady ask me at a seminar last week that I was doing for critical access hospitals, how do I get our leadership to understand that our billing department with our 25-bed hospital cannot do that? And I said, wow, you've given me a tall order. And I said, basically, the only thing I know to show you to do is to show them a sample budget, to show them the steps that I'm showing you guys, and then how much it's going to cost if you try to take the time to do it yourself, if you outsource it. They need to understand. And really, again, to get leadership engagement, you have to show them the baby, because they don't care about the labor. They need to understand the bottom line. Your providers, your CEOs or CFOs, if you're a bigger organization, they have to understand the full scope and impact. I would dare say that many of the organizations or the hospitals that I was talking to last week, their revenue cycle people are overwhelmed. And they're been tasked, you know, in different departments with trying to handle a change management situation. This is not just hire an outside project manager and think it's going to happen if you have a large organization. This is a huge change management situation. They need to understand the importance of ICD-10 readiness. They need to understand all of the moving parts, like you now understand that it impacts every area of your organization, no matter how large or small. And then they need to understand what you now understand, that there's a firm deadline for compliance, 100%. You know, on October 1st is it. You either get paid or you don't. The fourth thing I need to address in steps to get ready is staff training. This is going to be a huge cost. The bigger your organization, the more this is going to cost. And again, remember, if you do decide to outsource, or there is a big trend to do that to professional billing services or a company like MDeverywhere, that will take away some of this burden for you as far as the training. But let me just say this again, and I mentioned it the very first of the webinar. If you don't know where your staff is now and how good they are and what those numbers look like, if you don't keep a graph or some type of chart about reimbursement, how quickly you're getting paid, the mistakes that are made, denied claims or pending claims, if you're not keeping up with that now, how do you know how much money you're missing? If you have to have a way to evaluate your current coders and billers. And if your coders and billers on the phone, on the webinar today, I applaud you. You've got a hard job, and when it comes down to it, you have millions of dollars in your hand every year, depending on the size of organization you're with, and it's a big job. And many of you are going to have to recertify, like with your CPC, because you will need to do that for ICD-10. But we need to think about anatomy and physiology. You know, and I will tell you guys, I've heard everything from it's overrated to you better have them take anatomy and physiology classes, and you better have them start immediately. Now, for our clients, we're going to offer some of those resources, but I just want to say to you that you better know where you currently are, because if you don't know where you currently are with ICD-10 in relation to your billers and coders, you are going to fail with ICD-10. There is no doubt that you will. The fifth step, again, I think, and I've said this already several times on the call, is that physician documentation is everything. If we're going to get more specific, then we've got to get our physicians and our providers to write it. Because we all know in healthcare, the first statement I learned first day of nursing school 20 years ago is if you didn't write it, you didn't do it, or if you didn't write it, it didn't happen. So just because Sally, the coder, has worked for you, Dr. Smith, for 20 years, and she knows what you meant to write, and she goes and she pulls or codes that more specific code as ICD-10, even if she did it correctly, it is a huge area for RAC audit, because that's fraud and abuse, as we all know, just because you didn't chart it, she knew what you meant. Big problem. It's going to be a bigger problem with ICD-10. Part of reasons to outsource, again, some of what you're doing with your billing, or all of what you're doing with your billing, is to shift that liability. But ultimately, it wouldn't even matter. If your doctors are not documenting, your coders can't code. We can't get it right. So we'll talk more, and I always want to help my clients with physician engagement or provider engagement, and we can talk more about that. You know, if any of you guys decide to contact me, we can talk more about that. But that is a huge piece to making this thing work. Your physicians are going to need CDI training. They're going to need basically to tell a story. You know, whether it's a fracture or a cut, the size of the cut, where exactly it was located, what it looked like, what the blood looked like, what the infection looked like. I mean, that is how you're going to be able to pick that most specific code. The next few steps that I'm going to talk about, 6, 7, 8, 9, basically all involve contacting your vendors, whether it's your EMR, your practice management software, payers. All of these steps really are kind of similar ultimately, and that you need communication with all of them, and you needed it months ago. You needed to start dialogue and start asking some of these questions. What with vendors? Are there costs for upgrades in my contract? If so, if not, what is the cost? When will you know about the cost? How soon can we get an answer? Do you realize there are 17 questions you need to ask every vendor you have? I mean, how would you know that? You know, many of you guys don't know that. What is the transition plan? When can we start testing? Do you have a recovery plan in place in the event that your system has challenges? Have you tested, and can you accommodate 5010 in relation to ICD-10? And guys, there are many more questions, but these are just some sample questions. Again, the next slide, again, goes back to contacting, and you can call them vendors, but payers, your billing services, your clearinghouses. Then slide 8 actually talks about upgrading your internal processes. I've talked about some of the internal processes already, and you know, touched on if you're married to a super bill, you're in big trouble, right? But your encounter forms, split claims, dual coding. Some of you guys don't even realize you're going to have to do dual coding. You know, non-covered entities like workers' comp and auto insurance, and there's one more, and my mind just drew a blank. They're not covered entities under HIPAA, so they don't have to move forward with ICD-10. They don't have to comply by October 1st. So you will have to have dual coding capability. Let me say this too. If you have a free EMR, or you have one of those EMRs that are a smaller company or a smaller practice management company, even some of your small payers, they may sunset. They may not make the transition. So it's crucial for you to be asking all of these questions. Internal processes, again, that's step 9, thinking about everything that goes on with payment internally, with IT systems, with algorithms, every type of metric and measuring that you do, all the type of reporting that you do, all of those things need to be addressed. The final step is external testing, okay? So 9 is internal testing, which should have started in April of this year. Nobody's doing it. We're very, very far behind. Then step 10 is actually external testing, okay? So that's your payers, your hospitals, your HIEs. Also, we want to think about, when I talked about EMR companies, software companies sell software, okay? That's what they do. That's what they make their money. And then when they've made the transition and they've got your money, that's done, right? The difference where a revenue cycle management company like MDeverywhere comes in is that they're partnering with you. Everybody, they have to be in this with you together. If they don't get paid, you don't get paid, right? So, and I know for a fact that MDeverywhere has already got a sandbox for their clients that is allowing for internal testing to start already 15 months in advance. I mean, that's a huge thing that you need to be thinking about. Many of you have not even thought about internal testing, let alone external testing. All payers won't test. There's a lot of talk about that right now. What is ICD-10 going to cost? So now that you understand it's moving forward, you've seen the 10 steps and getting that process going, what's it going to cost? Again, guys, I've seen numbers all over. I've seen so many different surveys all over the place about the cost, between $18,000 to $60,000 for a private practice. Let me tell you, on average, if you have a 50-bed hospital, you're talking about maybe $500,000. If you have a 25-bed hospital, you're talking about $250,000. And when I say that, I mean for coders, for trainers, I mean for project managers, I mean for somebody to come in and take over and make sure that your team is doing what they should be and manage that whole project and bring in outside trainers. That's the kind of number you're talking about. If you're a single practice provider, you're not going to get past this or get off cheaper than about $15,000. And many of you guys, again, will absolutely want to outsource this somehow. I don't do that. I don't do project management for providers, but ultimately many of you will be looking to do that because your people don't have time to do it. There's other costs involved, and again, I went through a lot of this cost already. I want to show you, this is the budgeting areas to consider: your software modifications, education, your upgrades, staff time, downtime, additional staff if you don't outsource, consulting services, reprinting or data conversion, and the whole long list is there for all these areas. When you put it into a budget, and I'm sorry this is so bright green, but when you put it into a budget, this is kind of what it looks like, and you can see that the breakdown. And by the way, this is a RAND survey that was commissioned, so this is an independent survey, and this is a 5-provider practice, okay? So without software upgrades, right, you're talking about somewhere between $60,000 and $80,000 for 5 providers. All right, and there was a little bit of outside consulting done there, but not actually hiring a full outside consultant. Here's some other areas of possible cash flow. Again, I've got to go back and talk about, when vendors aren't ready, when they're delayed, when the payers aren't ready, when there's issues, when there's learning curves, you're seeing fewer patients because it takes the doctor or the provider longer to see those patients, and that's where CMS says providers should plan to have 6 months of operational cash. Listen, I work in private practice. I work on the backside sometimes. I know how little money hospitals and private practice have. Many are even non-for-profit when you get into hospitals. So I understand that to have 6 days of operational cash, again, when you outsource to a company like MDeverywhere with revenue cycle management, you can cut that in half. So that's just another perk. Yes, there's going to be front-end savings, but there's back-end savings as well. Then I want to recap before we open up for questions, but basically, if you're in private practice, you can have an internal person actually be the project manager. You need to get a team together, even if it's only 1 or 2. Get a clear communication plan. Some of you guys will consider hiring an outside project manager or getting a program like I've put together that is only a few $100 that will really help you. that you will need to do that impact assessment. You're going to spend hours on the phone with vendors. Just embrace that and accept it and get started on it tomorrow because you've got to do it. Then internal and external testing. Hospitals, the same way, or very large practices. I would say if you have 20-plus practices, you know, you're probably going to look for an outside project manager. Again, if you put it off, the price is going to go up. You retain somebody now because that's the thing to do. Appoint a steering committee and develop your communication plan. You would do your gap analysis or gap assessment, develop a training plan, and really part of that is provider buy-in, leadership buy-in, doctors with documentation. I mean, we have got to put the document into doctors because if we don't, there's going to be no money in the bank on October 1st, 2014. Identify your key stakeholders and then develop your testing process or a plan. Again, for some of you guys, that will mean outsourcing. So, Ellen, I'm going to open it back up to you because I'm sure we'll have questions. And guys, again, I know that I'm a fast talker. I'm often told that I'm really a New Yorker with a Southern accent. But ultimately, I know I've given you a lot of information, but I hope I've given you some great stuff that you can get started with your transition immediately today. And, Ellen, I'll open it back up to you.
Wow, Lisa, thank you so much. That is a tremendous amount of information, as you pointed out. And actually, the first question that I have is someone saying, that's a lot of information. Is there some type of resource available that would provide step-by-step guide to this? We covered a lot.
There is, and I'm the first not to talk about that a lot, but I actually wrote a 40-page guide, and I did create a slide in case we got that question, but a 40-page fill-in-the-blank. Guys, this is written so simple, a fifth grader can do it. It has recorded training. There's an hour free consultation. There's going to be coding training. There's going to be CDI training. Everything is available to you guys if you're on the webinar today. And there's the website. And right under MDeverywhere logo, which you've seen many times on this PowerPoint, if you go to TrainRX.net, it's there. You will have everything you need. You'll have access to me. And you can buy that for today for $349. Let me just say to you that I've had companies offer me thousands of dollars for this guide. So there's the answer to that. We have everything for you. Next question.
All right. We've got a question. How do we implement this now and do chart reviews when we're not using it practically prior to October of 2014? Staff is finding it confusing because they don't feel the training is effective this far ahead. So how do we implement now and do chart reviews when we're not going to start using this until October of 2014?
I love that question because here's what you're going to do. You're going to do today, you're going to use some type of free GEMS tool, and that's GEMS. And if you guys can contact me or Cindy at the email address on this slide, I'll actually send you, I'll tell you, Ellen, I'm just going to do that. I'll just send them, but ultimately you're doing a chart review. You're converting the code using a free GEMS tool. Then you're going to pull charts from every provider with your top diagnosis, and you're only going to convert your top diagnosis codes, let's say 20 to 50 or 20 to 80, depending on your area of specialty. And then you're going to pull charts and say, where is the documentation for my doctor? Is this provider good and this provider terrible? And you do the same thing in a large organization with hospitals. That's how you test and know where you are. You see where their documentation is today, and could you assign an ICD-10 code based on what they charted in the past charts for ICD-9?
Okay, terrific. We have another question. For claims with dates of service prior to October 1st using an ICD-9 code, if the claim has not been paid by October 1st, 2014, will the code need to be converted to ICD-10?
It will not. It'll always go by date of service. And again, you guys know I'm not a coding expert, but the answer to that is it's always going to go by date of service. That's why you will need to have dual coding capabilities. And your vendors know that as well.
All right, and to clarify, when can we start using ICD-10? Can we start using ICD-10 codes prior to October 1st, 2014?
The only way you should use them is just internal education so that your providers start looking at what they look like, get familiar with them, but no, you cannot submit a claim using an ICD-10 code until October 1st, 2014.
Okay. All right. How do we get the doctors engaged? That's a good one, because a lot of it's going to fall to them for the detailed documentation. How do we get the doctors engaged?
That's $1 million question, and the bigger the facility, and then you have hospitalists, and you have providers that have privileges, then we have private practice. So I mean, that really is a challenge. But basically, what you've got to do is you've got to hit them with the bottom line. You've got to say, here's some examples of some new codes. When I looked at some of your charts, or I did a chart on, here's what you're missing. Here's the sample budget. This is how much this is going to cost us. This is how I'm planning to start it. Or if we need to hire an outside person, listen, if you need to spend $10,000 to ensure your $7 million, if you have 8 providers, let's say, that's a great investment of your money. And that's the kind of thing you have to talk to a doctor. I've been chasing physicians and providers up and down the halls for 20 years saying, clarify this handwriting. Now it's better because of EMR, but clarify what you're doing. And at the end of the day, they didn't want me to talk and talk and talk. They just wanted me to give them the bottom line. What is this going to cost me? What do I need to do? And give me step by step. And I think that's how, in our recorded training that we have in our guide, that's how we talk to providers. That's really how we give it to them straight. So, I think that's the best way, is just give it to them straight and point it out to them.
All right. And I know we are running 1 or 2 minutes over, and there's a deluge of questions pouring in. Any questions that we don't answer on this call, Lisa or I will follow up with you immediately following this webinar. The last question that I have time for, and it's going to be a quick one, for a smaller, it's an 80-bed hospital, they're asking if your guide would be helpful to their facility.
If you have an 80-bed hospital, I'm not going to tell you that my guide is going to do what you need to do. My guide is perfect for 20 or less providers, but when you start getting into large organizations, you're going to need bigger resources. And I am connected, of course, to all types of resources for every size organization, whether it's the clinical documentation piece, whether it's staffing, whether it's training. I'm connected to resources to give you 100% of that, and all you need to do is reach out to me, and I'm happy to help you, happy to actually give you, if you have a hospital and you need a free assessment tool, I'm actually happy to give you that so you can kind of see where you are. But my guide really is written for those with maybe, 30 providers might be stretching it, but ultimately that guide can help those smaller practices, and you can contact me, and I'm happy to give you some resources for bigger organizations.
All right, terrific. And as I said, we do have a lot more questions that came in, and we will answer them as follow-up to the webinar. Lisa, I do want to thank you for all of the relevant information. Everyone should really have a better idea of what they need to do and when to do it. The guide is available to you. This was a lot of information. Feel free to contact Lisa directly. Her contact information will be included also in the follow-up email you'll get with this webinar, which will include a link. Just to let you know, MDeverywhere is doing our part to get information out. We have several ICD-10 specific videos posted on the MDeverywhere YouTube channel. Just search for us. And if you subscribe, you'll also get pinged and notified when we update more information. We've got a couple more videos in production right now that will be posted over the next 10 days or so. As Lisa referenced, ICD-10 prep can be overwhelming, all right? This was a lot of information. When you do work with a partner like MDeverywhere, it does lighten some of the load. As I mentioned earlier, we do provide process-built cloud-based technology back-end services to physicians in solo or group practices, as well as in a hospital environment. Lisa referenced what we're doing right now internally. We are completing our internal testing now, and we will be deploying a sandbox or a test environment for our clients so that they can practice and familiarize themselves with the ICD-10 compliant versions of their forms and their codes. Being prepared is not optional. You must do it. It's necessary to minimize the negative impact on productivity and ultimately your cash flow, your organization's financial success. So anyone who is interested in learning more about how a partnership with MDeverywhere can benefit your group is more than welcome to reach out to me. I'll be happy to schedule some time and we can go out, we can cover some of that. Or if you visit the MDeveryware website, fill out the contact form, we'll follow up with you. All right? We will follow up on any questions that were asked but not aired on this webinar individually. You'll get a copy of the recorded presentation, and that does conclude the presentation. Thank you again, Lisa, for all this very great information. Thank you to our attendees. I didn't know what the right word was, overwhelming.
It's great and overwhelming, and thank you so much for having me. I love to help people, and I appreciate being a part of it. It was great.
Terrific. Thank you, everyone, for spending part of your day with us. I know your time is valuable. Enjoy the rest of your day. Thank you very much.